I don't know if we want to take a roll call to make sure we have somebody from every AAA. That didn't occur to me till just now. I don't know, not that it really matters. Hi there. We are recording this, and I just want to say good morning, everyone, and welcome to the Appendix K Flexibility and PHE Unwinding and January 1 of 2024 rule updates. We're going to go over all the rules that have been changed or amended in any way and talk about the differences and talk about the clinical perspective. On Tuesday, last Tuesday, some of you may have been on the call with us as well, where our provider oversight area delivered this information. So our trainings mirror each other. So definitely we wanted to have it in the two different areas because, you know, you do different things on the provider side than you do necessarily on the clinical, but we all work together. So um, provider oversight recorded theirs as well, and they've already sent it out, and plus they've sent out the PowerPoint. So that's what we're going to do as well. We're recording right now, so any of you just be aware that we're recording you.
I'll have
Make sure you're muted if you're not talking or you don't want to be part of this historic moment, and we will go from there. What we can do is, as we go through the PowerPoint, we can answer questions. If it seems that we're at a point where we keep having a lot of questions in one area, we can kind of table it for a minute, and then at the end, when we have time, we can come back and talk about it, if that makes any sense. We just want to make sure we get through the whole slide deck and that everyone is able to see everything. As I spoke about to provider oversight when they had their meeting on Tuesday, they collected questions, and we're going to do a combined FAQ document as well. So it will have the provider oversight questions and it will have our clinical questions and answers as well. And some of them actually are kind of the same. They came to both of us. So, that's why we wanted to do a document together and make sure we're all in agreement. So, all righty. So welcome everyone. This is our agenda. Today we are going to discuss the final unwinding of Appendix K flexibilities. We're going to discuss rule updates, what has changed in our clinical recommendations. And then there is a new rule, OAC 5160-44-32, which is a brand new rule. And I think all of you have maybe heard about it or referenced it, where it is a direct care service worker rule. And so Lauren who is our participation directed manager, will go over that in lengthy detail. So, all right, next slide, please. So I have the rules in sequential order. So the first rule that has been updated is the home delivered meal rule. And I've got the citations at the top of every slide. So the meal menus will be approved in writing by a dietitian who is currently registered with the Commission on Dietetic Registration and who is also a licensed dietitian in the state in which the dietitian is located, if that state license dietitian. Providers will furnish each individual with home delivered meals that accommodate the individual's religious, cultural, ethnic, and dietary preferences. Providers shall also publish their current menu and ingredient information on their websites and offer written menus and ingredient information to individuals. So what we did remove, or what was removed from this rule, is the term of special diet. Also, they reformatted the person-centered plan element description, and they also removed prior deeming language. So let's go to the next slide. The new and improved rule will have better defined billable meal types, standard, kosher, and therapeutic. There will also be added flexibility to enable an individual to select what they would like with personal preference. Okay, next slide. So here's the updated definitions. The kosher meal means a meal that complies with the kosher practices for meal preparation and dietary restrictions, and is certified as kosher by a recognized kosher certification or a kosher establishment under Orthodox rabbinic supervision. So that's a little bit of an update. The therapeutic meals, which used to be known as the therapeutic diet meals, we dropped the diet, means a meal provided in accordance and in order by a licensed healthcare professional whose scope of practice includes ordering therapeutic diets. So the qualifying information is as part of the treatment for disease or clinical condition, to modify, eliminate, decrease, or increase certain substances in the diet, or to provide the mechanically altered food when indicated. Next slide, please. The standard meal means a meal that adheres to the version of the dietary guidelines for Americans in effect on the delivery date and at least 33% of the individual's dietary reference intake. The standard meal may include, but is not limited to, a reduced calorie meal, reduced sodium meal, reduced sugar meal, a gluten-free meal, or a vegetarian meal. Okay, next slide, please. So the clinical recommendations for case managers. So with our folks that are currently receiving home delivered meals, um, let me see here. Can a meal provider offer therapeutic meals at the standard rate? I'm not sure about that, Kathy. We'll write that down and we'll get that from the provider oversight area. So thank you for that question. Home delivered meals. So you would identify individuals on your caseload that receive home delivered meals. So Kathy says, we have providers that do this. Yes, I understand. And I don't think that there's been a change, but I don't want to speak directly. The PowerPoint that we have from Tuesday has the actual rules. What I've done is I've looked at the rules and taken out information and put them in a clear language sort of thing that case managers are used to dealing with rather than a rule format. So we will go back and look at that and make sure that that is the intent or that that still is in place. So we want to make sure I understand what you mean. So we can go forward with that. Okay, we see 9 and 11. It's on the call as well. So, all right. So the first step is to identify individuals with home delivered meals on their caseload. They would want to discuss the new definitions with the individual and confirm their type of meal.
Alicia,
You're muted,
Yeah.
Alicia.
Muted me. Someone muted me. Thank you. I guess that tells me I should just stop, right? All right. So the case manager should review the types and specialty meals. The start date, if there is any change, this is available as of 1/1. So if there is any change, that would be the date that these new meal types and these new specifications come on board. So that would be the day. They don't have to change them on the first, but if they need to or they need to update it or change a provider, just keep in mind that all of these rules that we're going over reflect the January 1, 2024 start date. So, and many people might not have any changes at all, that's fine. So we want to review the types and the start date. If an individual requires a therapeutic meal, there must be an order by a licensed healthcare professional in the record. So if someone currently has the therapeutic diet meal, and they already have a current order in the record or in their documentation, that's fine. You don't need to do it again. I mean, that covers until the next round or, the next RA. And also to ensure the meal type is consistent with their preferences. So next slide, please. So right here is clinical guidance, and this is a care plan. So we're going to cover care plan expectations, service plan expectations, and case note expectations. So these are our clinical recommendations regarding the home delivered meals. So these are examples. Example of the care plan. The implication may be the individual is in need of home delivered meals, and then you can insert the reason for the meals and the type of meals selected. Goals. The individual dietary needs will be met. Insert additional language unique to the individual. And then the intervention, the individual will receive therapeutic meals for management of diabetes. Just another example of what you could put down. Then you can insert the name of the meal provider and the cadence of which the meal will be delivered, including who will be signing for the meals and the method of signature. So as we know, some meal providers do like a 14 meal drop once a week or once every 2 weeks or whatever the cadence is. Um, it's best to have this in the care plan again, as we're really working on care plans, the person-centered service plans. So we want that to be updated. So this is the perfect time to make sure that these are updated, and the examples are the examples. You can copy them, you can use them, you can do whatever else, but there does need to be a statement in there somewhere where it reflects, why you're picking them, what the goal is, and in the intervention. So then following over to the service plan expectation. So this is an example of a service plan report. The individual has selected frozen therapeutic meals. The individual requires 2 meals a day for a total of 14 meals a week delivered every Tuesday. So you can put that in the comments. You don't have to, but it adds additional clarification. And I think most people already do it, that they might. And so on the service plan, you might not necessarily have to say the name of the provider because it's on there. So, you're going to fill out the service plan and you're going to put ABC Home Meals, whatever, and Mrs. Smith, and you're going to fill it out and you're going to put in the cadence in there and it's going to set up. So if you want to make additional comments, you could, and these are examples. The comment should include the particular meal type, delivery schedule, frequency of the meal, and the additional unique instructions, which is what the example above does. So then also in the case notes, at a minimum, it should include the conversation with the individual about the discussion regarding the meals and the types. If any additional work was necessary, example, if the individual wants therapeutic meals, the CM shows the calls to the healthcare professional for written approval. You can insert any additional information regarding the contact. Notes indicate the care plan and the service plan was updated, and date the person-centered service plan was sent to the individual and to the provider. So those are the type of things we want to see in the case notes. All right, next slide. All right, so we're going to go on to home maintenance and chores. All right, so the new service for this service spec includes upkeep and maintenance task for home modifications and adaptive assistant devices. So this is routine maintenance plan, extended warranty, service call, labor, and parts for a modification or device that ceases to function as intended. So, okay. So great. We have people putting on in the chats that if their AAA is being represented. If you all want to do that, that's fine. I think we do have a representative from every area, but you can certainly put it in there. So also the updates on the maintenance and chores. New services for this spec include removal of environmental hazards and upkeep, non-routine disposal of garbage or any other accumulated items in the individual's home, non-routine yard maintenance, including snow removal, pest control and related tasks to prevent, suppress, eradicate, or remove pests, and mold eradication. So those are new. So, okay. Also, the updates, the authorization of the home maintenance and chore may be combined with other waiver services to meet the assessed needs of the individual. In such instances, the individual waiver service limits of this rule still apply. Home maintenance and chore may only be provided by an agency or a non-agency provider approved by ODM or certified by ODA as a Medicaid waiver provider of home maintenance and chore. So what they did remove was the allowance for the service to be accessed 180 days prior to an individual's transition from an institutional setting into the community. So that was removed. That overall, the 180 pre-enrollment, all of those have gone away. So as we go through this, we will touch base on that as well. All right, can case managers educate on meals at the next scheduled contact or Is there a timeline? No. So if people are still, since we are in December already and it's moved so quickly, we're on December 7th. No, absolutely. If the case managers are making their normal contacts with folks at the end of December and they have this information and they, are talking to Mrs. Smith, great. Go right ahead. You can make any documentation that you want prior. You won't be able to change anything if it's an addition, if it's a different service or anything like that. If it's not already in the system, it won't let you add it. So if there's something that's new or unique, it won't let you add it as far as on the service plan report, but you could put it on the care plan, and then have it prepared already for when you're able to do the service plan report. If you don't need a change on the service plan report, then it shouldn't be an issue. And again, you can just put it in your notes that discussed meals, like as they have their template for every visit, discussed meals, currently receiving blah blah blah, and they want to keep doing that. So okay, the question is, do you know why the 180-day allowance was removed? Hi, Sue. Yeah, I'm not for sure. I do understand that was a CMS directive. I mean, I have my guesses. I'm not really certain about that. However, and we'll get to it, community transition service in the regards related to home choice still has the home choice rules attached. So we'll get to that later in the slide. But all right, that's a great question. Okay, so where are we? I think we're done with that slide. So on to the next one. All right, so clinical recommendations for case managers of home maintenance and chore. So again, this is just laying out the care plan expectations, service plan expectations, and case note expectations. Example of a care plan. The individual needs home maintenance or chore. The individual has roaches, and previous treatments have included the individual spraying for roaches, and the apartment complex has attempted extermination. Insert reason for the service need, including previous interventions related to this service needs that have been previously tried and addressed with this issue. So that is kind of that perspective of talking about past interventions, that justifies whatever step we take forward, but it also is part of HCBS settings rules where you talk about what's been extended, even though we're not talking about this in context of HCBS settings rule, but it just goes in flow with that. And it makes sense that, we want to know what's happened. We don't want to see that you're bug bombing someone's house, every month to the tune of, $1,000 or whatever. I mean, if they need it, they need it, but we want to make sure to show that, we tried the lesser interventions or, individual suggested interventions. I mean, if it's something that the individual says, well, I want to try this first, we can always do that. And again, it's up to clinical judgment. The case managers can talk to people and tell them about whatever service they may be requesting if they have any experience of, this traditionally doesn't work, but we can take this step first and see how you'd like to move on. So again, there's always the clinical judgment and the clinical discussion with the person and the informed choice. So none of that has changed. So we're still using that as our background. So I put this example in here just because, that's something that does pop up quite a bit about pest information. So then the goal would be the individual's health and safety will be met. And again, insert any language that is unique and individual to an individual. And then the intervention, the individual will receive home maintenance or chore, including, and then you put the scope of the work, pest destroyers, once a month, hot treatment, they're going to do whatever it is they're going to do. So just like they would normally do, document what's going on. Okay. I have another comment over here about the 180-day approval. So since the 180-day approval is removed, that means the member must be in the home for the service to be initiated. Yes, that is my understanding. As we go on, like I said, when we get to community transition service, we'll talk about that a little bit more because of the flexibility of people who are in the home choice, who have had the home choice assessment and who are working with home choice. So there may be a little flexibility with that. But yes, for this type of situation, again, I'm not sure exactly why it was removed, but it was at CMS's instruction. So that's where that came from. All right. So then there's a service plan expectation, which again, you can move. Chore is scheduled for 12/15/23 for pest removal. with comments. And then the case note expectation, the conversation with the person. These are all pretty much following in the same suit, obviously. Conversation with the individual about the discussion regarding the service need, if any additional work is necessary. Also the process. So if you're going to send out bids to find the provider for the individual, I mean, if you only have, our rules generally say you want to send it out to 3 people. That, if you're going to, and you only have 1 or 2 providers in your area, make note of that. That's why I'm only sending this to pest destroyers, All right. We need more space to notate in the care plan. I agree. That's something that is definitely on everybody's radar, as we move towards PIMS modification and computer or modernization. I'm sorry, not modifications. Is there any consideration increasing rates? Is the home mods from 10K due to higher costs? Um, I don't, I don't really know. Everybody is getting an increase as of January 1. So all the provider types are getting an increase. Now, the $10,000 per service is per year. If for some reason, it's per calendar year. So if for some reason somebody exceeds that, we can always talk about it if it's health and safety concerns, if it's warranted, if, if there's anything like that. So we can always talk about that. And we have brought that up with ODM as well. Has there been any consideration with inflationary issues? And the thing that is so different in Passport as opposed to Ohio Home Care Waiver, the ODM fee for service waiver, is that they actually have different pots of money. So although the cost cap has risen for all of our programs in an aligned amount of $14,700 per month, those folks can also access an additional $10,000, like not within the cost cap, so to speak. So in Passport, it is within the cost cap, but due to the fact that the cost cap has been, increased so substantially, because we were always used to working with those really low numbers. That was kind of Passport's claim to fame over the years, of working our magic with lower amounts of money and resources. So, and again, if a case manager has questions about stacking services or how to bill for them to make sure that they don't exceed like a monthly allowance, we can work on that too. You can work on it internally, or you can always bring it to our attention as well. But oh, thank you. Yes, we try to make ODM apprised of all of our concerns and questions. And they've been great working with us on things of that nature too. So we're just trying to make sure for alignment that that's the situation. So, okay. All right. Next slide, please. Home modifications. So the update, this rule was actually rescinded and replaced with a new version effective 1/1/2024. The rule is being filed as a rescind new, as more than 50% of the rule is being amended with the addition and recession of text. So what does that mean to real people that don't look at rules all the time? That basically means that when we are updating rules, whether it be for a 5-year rule review or an update like this coming out of Appendix K, for whatever reason, if 50% or more has changed, they're just like, we're going to scrap the whole rule and start from scratch so that we don't need to focus on, particulars, because it's really hard when you have that much of a change. So this is like a brand new rule. And again, it's effective 1/1/24. The new rule allows for this service to be combined with other waiver services, just like the rule before. The authorization of home modification services may be bundled with other waiver services to meet the assessed needs of the individual. In such instances, individual waiver service limits of this rule still apply. So that's talking about the $10,000. So, all right, next slide. So our clinical recommendations for case managers. So home modification individuals. Again, this is not like Meals on Wheels. This is not like home delivered meals where somebody's getting this on a routine basis. So I'm approaching this from the clinical recommendation that it's always going to be new. However, if you can identify individuals on your caseload that have had home mod services that are actually set up to be delivered after January 1, which again, home mod, we know we have a really small pool of providers to pull from. So sometimes it does get backed up as far as when they can deliver their services or, whatever it is. So again, if you do have any already pre-existing ones, just make sure that you're aware of them, that the case managers are aware of them, and that they review the identified individual's requests to ensure the new service specs meet the original request or bid. I can't think of anything offhand that would really have changed that would be that much of an issue. But certainly, again, if there's any questions, let us know. So if no, contact the individual to discuss options. If you're starting with somebody fresh, follow up with the provider about what will or will not change with the original bid. Again, as always, obtain warranties or factory information from the provider when applicable. And then as you update the person-centered service plan accordingly, care plan, service plan report, send updated PCSP to the individual and the affected provider. So next slide. Okay, here we are with community integration. The updates, the name change from community integration services to community integration. I don't know why that was necessary, but there it is. There are 3 ways an employee may be qualified as a supervisor of community integration. One of those options was for the employee, they had to have had 3 years of employment experience providing community-based social services or job coaching. The criteria for supervision of this particular service type has been changed from 3 years to 2 years for supervisor qualifications. They also removed deeming language, and there are no clinical practice changes for this specific specification. Right, next slide. Personal emergency response systems. So new and improved rule, PERS equipment means equipment that is appropriate to meet the assessed needs of the individual as authorized on the individual's person-centered service plan and shall include that meets all of the following characteristics. So it includes an activation device that is wearable and water resistance according to the generally accepted industry standards for water resistance to a level matching the individual's assessed needs and preferences. It has an internal battery providing at least 24 hours of power without recharging, accommodates the individual's needs and preferences of the individual. Next slide, please. PERS does not include remote video monitoring of the individual in his or her home, systems that connect to the individual to only emergency service personnel. They've removed notifications shall be sent to the station if the battery level is low. So that's been removed. And then the deeming language that was originally put in for Appendix K. So again, there's no clinical practice changes for this service specification. This is just an updated rule. Okay, next slide, please. Waiver service rule. So updates, payer sequencing. Waiver service will not be used in lieu of similar services available through third-party insurers, community supports, and available resources, including Ohio Medicaid state plan services when it has been determined an individual needs can be met by those services. The amended rule now permits spouses and relatives to serve as a direct care worker for certain waiver services. And the last bullet goes in consideration with our new rule. Parents of minor children, spouses, or relatives appointed legal decision-making authority may serve as direct care worker in accordance with the new rule. So somebody's talking, they're inviting people in. That's good. We want everybody to come. Wonderful. So this is in accordance with the new rule 5160 44-32 that we referenced at the beginning of the training, and Lauren's going to talk about that when we get through all of our existing rules. So, okay, next slide, please. These are additional updates about waiver nursing services. Non-agency LPNs under the direction of an RN. They conduct a visit with the directing RN at least every 60 days after the initial visit to evaluate the provision of waiver nursing services and LPN performance, and to ensure the waiver nursing services are being provided in accordance with the approved plan of care and within the LPN scope of practice. The visit may be conducted via telehealth and conduct an in-person visit with the individual and the directing RN before initiating services, and at least every 120 days for the purpose of evaluating the provision of waiver nursing services, the individual's satisfaction with care delivery, and the LPN performance, and to ensure the waiver nursing services are being provided in accordance with the approval of the plan of care and within the LPN scope of practice. So this also allows for the required visits from RNs and LPNs to evaluate waiver nursing services to be conducted via telehealth, and require those assessments to be billed using the state plan nursing assessment code. So if they are sending out an LPN and they do have an oversight nurse, RN, which is required, the nurse would bill for her services, the RN nurse would bill for her services using the state plan assessment code. So when an RM performs an RN assessment, oh, this is what I just said. The RN will bill within the assessment code set forth in Appendix A to the Rule 5160-12-06 of the Ohio Administrative Code. That rule is regarding state plan services. So that's what the 5160, it's a Medicaid rule, and Chapter 12 indicates state plan services. So just for your knowledge, for those of you who like to look things up and see them. So next slide, please. So clinical recommendations for case managers about waiver nursing. So if you have someone on your caseload that has waiver service, so you want to identify those persons, review the individual's record to ensure nursing services are still appropriate. Review the payer sequencing to ensure the necessary nursing activities and tasks are still appropriate as waiver nursing. Make a referral to the appropriate agency, provider, or insurance if there's other payment options may now be valid. So what I did too is I put down here our payer sequencing. So, and this is something we can talk about more in the new year, especially related to nursing. So it's important with all of our services, and waiver being the payer of last resort. So if we have payer sequencing, obviously if someone has a third-party insurance, that's the first hurdle that we would try to accomplish to see if they cover nursing visits. Medicare nursing, again, usually that is associated with an event or some ongoing issue that is covered by Medicare. The next step is private duty nursing via the Ohio Medicaid state plan. So the one thing that we must remember is the PDN nursing must be in blocks of 4 hours or more in length, but less than or equal to 12 hours in length per nurse on the same day or during a 24-hour period. And so we have a question here. Does PDN need to be approved by the PDN unit, or can that be approved by the PAAC? From my understanding, that's still going to be submitted. I will double check with ODM. They were having a change in Jim Gleer, who did the PDN reviews for years and years. He's actually retiring. So I can double check with them to make sure that whatever their process is, I can provide you with the information, the most updated information. So that's good. Let's see here. Thank you, as we would need the PDN acuity tool for Passport versus Ohio Home Care Waiver. So definitely. And from my understanding, it's the same one. You know, I've seen it because of my work with Ohio Home Care Waiver. But yes, we'll make sure. I'm pretty sure it's the same exact tool, because that's just a universal tool that is, again, referenced in that 5160-12 chapter of state plan Medicaid services. So, okay. So then after private duty nursing, so you're like, okay, my person doesn't need 4 hours or more. So that takes away the PDN need, right? There's still Ohio Medicaid state plan up to 14 hours. So that 14 hours, as we know, includes nursing and skilled services and home health aid. So if that 14 hours has been exhausted by other services and nursing needs to step out, you can do that. And then lastly, of course, waiver nursing is the payer of last resort. So let's see here. Also question, read the PDN process. That would be helpful. Great. I'm glad. And I think I referenced it in the guide. And when I did touch base with them a while back, I know the guide is in process and, that sort of thing. So that was something that is in the guide that will be sent out eventually. But I will definitely make sure so I can give you the guidance on this before, but then we will put it in the guide. So we're trying to include things like that. So, okay. All right. Any other questions or concerns about this? Okay. So again, let's see here. And waiver nursing would be for blocks of less than 4 hours of time due to the requirement for the 4 hours of more to be PDN. Right. So that's where we did put in state plan services though. So if you have somebody who is not getting any state plan services, um, then if possible, again, depending on the task, a lot of it's related to the task. Like if they're just doing vitals, which I think in my next slide, we're going to talk about a few examples, like things that are related to maybe an hour of nursing once a week, like med setup or, those kind of things that Medicaid state plan will cover. It's definitely better to use that first. And then, again, but waiver nursing is available if these other services aren't available or applicable, or if they don't need to be 4 hours. So that's something to keep in hand. So, okay, also, if someone has a third-party insurance, but they cannot afford the copay or deductible, can we authorize waiver nursing? Ashley, let me take that back and see what we can find out about that. So, thank you. That's a great question. And I know that came up several times in my former life at ODM. So we will see what the most recent guidance on that is, and we will get back with you. We're going to add that to our list of FAQs. So thank you. Okay, next slide. So again, here are the examples of care plan. The implication is to address the need, the med setup and vitals. That was the care plan example I gave because that's the one I think of most, most of the time related to waiver service, waiver nursing service. In there again, you're going to insert the reason that the other interventions are not applicable for whatever reason. If it's just an hour, you don't have to say PDN is not necessary because we should all know the rule about PDN. But you do want to say, something about payer sequencing or the previous interventions have been tried, and this is why we are covering it under waiver nursing and maybe not state plan 14 hours, something of that. And again, in this example, the individual's meds will be set up properly by the nurse as the individual is not able to do so. Again, you can insert all of the specialized person-centered language here that we want in our person-centered service plans. And then the intervention simply being the individual will receive waiver nursing. You can put in the provider, you can put in any additional information. So then on our service plan report, our examples are waiver nursing is 2 hours on Mondays at 3 p.m. And then again, you can have your comments of anything that's unique that you want to put on the service plan so you make sure that the provider sees it. And then case note expectation, the conversation with the individual about any kind of service need or update, additional information. So if we say, example, the bid process was to find the provider for the individual, the individual's consent, insert any information regarding the contact, update your notes, update the person-centered service plan, and make sure you send it to the individual and the provider. Let's see here. Okay, let's see. Did I read somewhere that the name and contact information of the RN supervising the LPN must be included in the service plan comments? Linda, I don't recall that, but if it is there, I will go back and look at that. it needs to be somewhere in the care plan would be my recommendation, and in the notes, just because if the LPN is being done, I mean, if this is through an agency doing waiver service, usually they do all of that information and they have the service specs related to that on how that must be documented. If it's an individual provider waiver, nursing provider would be probably the only time that would come in. So I'll go back and look at the beginning of the presentation, and if it does say that, I will change it, because I don't think it needs to be in the service plan comments. It always can be. There's no problem with that, but it doesn't have to be there. But it needs to be in the documentation somewhere. So if they're a non-agency provider. So, okay. All right, community transition rule. So updates, again, the name change from Community Transition Services to Community Transition. So for all of us used to saying CTS, it's CT now. So let's see here. New, expenses necessary to enable an individual to establish a basic household. Examples include security deposits and rental fees needed to obtain a lease on the apartment or home, and rental expenses required to obtain residential lease. Essential household items such as furnishings, moving expenses required to occupy and use a community home, including furniture needed to occupy and maintain housing, including window coverings, food prep items, and linens. It also includes setup fees and deposits for utility and service access, including telephones, cell phones, electricity, gas, garbage, and water. So they are calling out in this rule a few more things than they used to. So next slide, please. And the update. So, oh, it's in the new draft of the PAA manual. Tracy Nowers answering our question. I'm sorry, I'm jumping around here to go back to the question about the RN supervising the LPN. Okay, we'll look at that. We'll look at that. Thank you. Amy, will you make sure that you put that on the FAQ, even though it's in relationship to the manual, so we can make sure we look at that too. Okay, let's see here. Updates. So services necessary for the individual's health and safety, such as pest eradication and one-time cleaning prior to occupancy. Pre-transition transportation necessary to secure housing benefits. Initial cleaning and household supplies. Activities to arrange for and to procure other non-reoccurring setup expenses. And essential personal hygiene and clothing items may also be needed for the transition to transition safely. So that was always kind of an issue before. I think, clothing was an issue that had come up over the years as being an issue. So it is in here now, so that is something that can be addressed, because that's often an issue. Also new, the provider's administrative cost associated with providing community transition under this rule. So they can bill for their costs, or their administrative costs, which is different than the past rule. So, okay, next. So updates. Community transition does not include, and this is a new rule, furnishing living arrangements that are owned or leased by a waiver provider where the provision of these items and services are inherent to the service they are already provided. The provider will involve the individual and or caregivers in the selection of items to be purchased on the individual's behalf. And then again, they removed deeming language. There are no clinical practice changes for this service specification. So next slide, please. Home care attendant service, not to be confused, of course, with Choice's home care attendant service. So this is the definition. The home care attendant service are services provided to an individual enrolled on a waiver by an unlicensed non-agency provider in accordance with this rule. Home care attendant services are tasks that would otherwise be performed by an RN or an LPN at the direction of an RN. Although the names are similar, the service is different from Choice's home care attendant service, which is for self-direction and individual providers. So they also modified the record keeping to eliminate the requirement for the clinical record to be stored at the provider's place of business. And they also modified temporary flexibilities, allowing the individual's signature to be obtained at a later date. Next slide, please. So they removed. So these are some of the things they removed. I don't know how widespread this service is, but again, it is something that I know is used a little bit more in Ohio home care waiver, but it's certainly available to the passport consumers. So they removed the requirement for continuing education hours, removed the temporary flexibility, allowing CPR and first aid to be obtained solely through internet training. They removed the requirement for a separate record to be maintained in the individual's home if the clinical record is accessible in the home. Um, they removed duplicative language describing group setting service authorization, and they reinstated requirements for face-to-face RN visits, and they removed deeming language. So again, we do have someone asking the question, okay, so Kristen's saying yes, they do. I did just get an email about the guide, so hold on, let me look over here at my emails real quick and see if there's something, if it's an update or just additional information. Um, okay, so Kim Mobley sent me some updated language that's in the guide. So I will look at that when I reference that, when I say that I bring back, when Linda asked the question and we kind of talked about it. So I will make sure going back to that RN supervising LPN information and what's in the guide. So I will make sure that, Kim's identified the exact place. So I will go back and look for that there. So thank you, just to kind of move on from there. So anyhow, so Kristen says they have in 10B that they have people using home care attendant. I'm not sure. We could always run a report. I don't know how many folks are using it, but it is available. So, okay, next slide. Okay, I'm going to turn it over to Lauren. Thank you so much for listening to me, and I appreciate all your questions. Thank you.
Hi, everyone. My name is Lauren Walter. For those of you that don't know me, I'm the Participant Direction Manager. But today I'm presenting on the new rule that's coming out, and I'm on Alicia's team, which is the clinical team. All right, so the new rule that's going to be coming into effect again, along with all the rule changes on January 1st of 2024. It's the 5160 4432 rule, and it's called Home and Community-Based Medicaid Waiver Program Provider and Direct Care Worker Relationships. So this is the rule that's going to allow some spouses and legally responsible relatives to be the individual's direct care worker. All right, so again, takes effect on January 1st, along with all of the other rule changes that are going on. This is a Medicaid rule. So as you'll notice, if you've already read it, it is a rule that applies to ODM, ODA, and DODD waivers. So if you're looking at the rule and you're like, this doesn't apply to our passport folks, that is why. It was designed to be all-encompassing of the waivers that fall under all of those departments. And if you have not already, I definitely recommend reading the rule. The draft proposal is out there, so definitely recommend reading it. But for the sake of this training, we're actually going to be going through each element of the rule that applies to our passport waiver. And then another thing, ODM does have recorded webinars coming out. One has already come out. That is the one that's about the extraordinary care instrument. So that's available. There's a recorded webinar and a PowerPoint available for that. And then they are still working on an overall rule overview that is not yet available. They were hoping it would be done in time for our trainings today. Unfortunately, the timing didn't work out, which is fine. So we'll be going over our guidance today, but when that is available, we will absolutely share it, and we encourage everyone to listen in on that one as well. All right, so as it relates to this rule, anytime there's a request for a spouse or a relative with a legal representative designation to be the direct care worker for the individual, then an assessment should be completed to determine if the requirements in this rule can be met And the spouse or relative with a legal representative designation can or cannot become the direct care worker for the individual. So if it's requested, we just want to, reference to this rule and see if the individual qualifies for this. And another disclaimer I wanted to make, as we've been going along in this training, we try our best to anticipate questions and provide guidance accordingly. But I anticipate there are still going to be questions that we may not have the answer today. So Amy's taken down questions and we'll definitely get back to you guys with that FAQ Alicia referenced. So this rule applies to the following services. So homemaker services through an agency, personal care services through an agency and participant directed, waiver nursing through an agency, and then the choices home care attendant participant directed service. And then within this rule, there are kind of two relationship categories with two kind of different qualifications. The first one is parents of minor children or spouse of the individual. For the sake of our program, spouse of the individual. And then relatives of an individual above the age of 17 years with a legal representative designation. So in this training, I'm going to start with what are the requirements for the spouse of an individual, then I'll move to the requirements for relatives with legal representative designation, and then I'll have a category for things that apply to both of those categories. And then just for the sake of this training too, I reference rules in this, and I've kind of taken out anything that doesn't apply to us. So like if there was a reference to parents of minor children, I just removed that for the sake of not adding any confusion in this space. All right, starting with the spouse of the individual. All right, so the first two big things you're going to want to look at to see if a spouse qualifies to be the direct care worker are these two things. First is there no other willing and able provider or direct care worker available to provide the waiver service to the individual? That's me, the first thing. And then the next is, can ODA or their designee has determined the health and safety of needs of the individual can be ensured using that spouse as the direct care worker. So just to go into a little bit more guidance around these two. So again, these two things must be able to be met in order for the spouse to be the worker. So some things that we anticipate may come up. If an individual chooses not to use a willing and able provider, they will not meet this eligibility criterion in the rule. And then if an able and willing provider or direct care worker can only do some of the hours the individual is assessed to need, then the spouse can do the remaining assessed hours. The hours the spouse is authorized cannot exceed 40 hours a week or the amount the individual is assessed to need, which we'll actually talk about in more detail a little bit later. And then this is an ODM expectation that's going to apply to all of the waivers. The PAA shall complete a provider search that lasts 10 to 15 calendar days with re-engagement every 4 to 6 months, utilizing your typical methods for provider search, such as contacting applicable providers directly or posting a request for a provider, whatever your PAA's best practice is there. So ODM wanted a general expectation for kind of what does a provider search look like before we actually determine that there's nobody able and willing. So this was the best practice there. And then if a spouse is found eligible under this rule and working as the direct care worker and later an able and willing provider is identified, the spouse is no longer eligible to be the direct care worker. Once the new provider can start, the PAA should complete the transition within 30 days. Again, that's a best practice that falls under all of the departments. And that kind of circles back to this 4 to 6 months, kind of re-engaging with a provider search. If at that time you find a provider, then you'd follow this guidance. So that's the first piece. And then the second one, has determined the health and safety needs of the individual can be ensured. So if there are concerns that the spouse is not or would not meet the individual's health and safety needs, review internally how you typically do with any health and safety concerns. And then absolutely ODA is always here for consultation as needed if you want to talk through a specific situation. All right, so those two things are met and we can keep moving forward with seeing if the spouse can be the direct care worker. So when conditions set forth in E1, which is what we just reviewed, are present, the spouse of an individual may serve as a direct care worker within the following parameters. And there's actually a few slides with this as well. So the big thing, which it has its own training, as you guys are aware, is this extraordinary care requirements. So HCBS waiver services provided by a spouse must meet extraordinary care requirements as determined through the prescribed form ODM 10372, Ohio Extraordinary Care Instrument. So this would be another requirement for if a spouse wants to be a direct care worker. The case manager would need to do this extraordinary care instrument tool with the individuals to screen to make sure that they meet this extraordinary care requirement. It must be completed for the first time when spouses who are currently authorized under Appendix K flexibilities. Again, we'll kind of get into that a little bit later as well. And then it must be completed for spouses who request to become a direct care worker on or after January 1st. And then following that, the ECI must be completed on a reoccurring basis, so annually at their redetermination, and then whenever a significant change in the individual's needs or condition occur. Specifically with this, it's going to be a change that could maybe impact their qualification with this ECI tool. All right, and again, if you haven't watched ODM's webinar, I definitely recommend it. They go into a lot of detail over the tool and their expectations around kind of how to fill that tool out. And then again, when conditions set forth in E1 are present, the spouse of an individual may serve as a direct care worker within the following parameters. I won't keep repeating that for each slide. Individuals agree to and cooperate with monthly care management agency or services and support administrator contacts. Contacts may be a combination of telephonic and in-person visits with no more than 60 calendar days between in-person visits. So it is gonna, for these folks, if we deem them eligible to be able to provide, to be the direct care worker, then this contact schedule requirement would apply. And it really is just kind of a philosophy of checking in more regularly with the individual for a little bit more additional oversight. So just a little bit more guidance there. Contact is made with the individual every 30 calendar days. So that can be a phone call, and then every 60 days would be an in-person home visit. And then just to give a little guidance around what does this contact include, kind of our minimum expectations is just reviewing the following questions. Is there no other willing and able provider or direct care worker available? Something just to continue to check in on. Again, your re-engagement every 4 to 6 months. Are the individual's health and safety and care needs continuing to be met? Are there any concerns there? And are there any significant changes or needs that need addressed? We understand other things could come up during these conversations, but at minimum, this is kind of to help guide you with that conversation. And then something you can consider using at the PAA to help with tracking, since this is going to be more than that 90-day in-person home visit you guys are used to, would be you can go into the consumer chart under consumer eligibility period in the enrollment screen. Monthly contact can be chosen as the contact interval. So if you want to incorporate that into your guys' internal practice, monitoring for deadlines, you absolutely can. So just wanted to throw that out there. So again, and the consumer would need to be agreeable to this contact schedule as well. All right, another expectation, the spouse participates in contact and visit requirements described in the individual's person-centered services plan. So if it is determined that the spouse needs to be present for the contacts with the individual, then this must be documented in the individual's care plan, and the spouse should be present for the visits. Again, use your clinical judgment in those situations. Just know that if it is needed for the spouse to be at those contacts that we're just indicating that in the care plan. And then a spouse appointed as a legal guardian of an individual must maintain evidence of the guardian's ability to be a direct care worker for the individual in accordance with 6604 and rules of superintendent for the courts. So our guidance here, and if this changes, we'll let you know, but at this time, if the spouse is also the individual's guardian, then the PA should ask for the paperwork appointing the spouse as the guardian and keep that with the individual's record. All right, two more things. The spouse is employed through an agency provider, provides an eligible participant directed service through an FMS. It kind of goes along with just the applicable service, the services that this applies to. And then services provided by a parent of a minor child or a spouse may not be provided for respite purposes. So when you're getting to the point where you're actually determining, using your guys' assessment tools to determine how many hours you're going to approve, just know that respite cannot be a task that we're authorizing time under. All right, so that's spouses. Again, there's just a couple slides for relatives, and then we'll go over all the things that apply to both relatives and spouses. All right, so there's two categories with relatives. The first one we acknowledge will not really apply to too many of our clients, but we do know this situation happens every once in a while. So there's guidance in the rule around it. So a parent of an individual above the age of 17 years may provide the services described in paragraph A of this rule while holding the designation of authorized representative, declaration for mental health treatment, general power of attorney, healthcare medical power of attorney, representative payee, or guardian. So if a parent holds one of the above legal authorities, then they can be the direct care worker for the individual if all other applicable parts of the rule are met. Again, this doesn't happen often, but when it does, just know that it is able to be done. And then again, same thing for guidance around obtaining guardian paperwork. And then the next category is every other relative. So adult children, grandparents, grandchildren, great-grandparents. Again, that would not really apply to us. I would be very surprised if it did. Great-grandchildren, brothers, sisters, aunts, uncles, nephews, nieces, and step relations may provide the services described in A of this rule while holding the designation of authorized representative, declaration for mental health treatment, general power of attorney, healthcare power of attorney, or guardian. So again, very similar to the last slide, if one of the above relatives meets, if a relative meets the above definition of relative and holds one of the above legal authorities, then they can be the direct care worker for the individual if all other applicable parts of the rule are met. And then, another thing about the guardian paperwork. All right, so relatives with a legal designation, much simpler. So those two, first initial things, able and willing provider, those don't apply for relatives. And then also the ECI tool does not apply for relatives. Just remember those three factors are specific to spouses. All right, so these are all of the things that apply to both spouses and relatives. All right, and these really focus on kind of limitations. So unless otherwise permitted in this rule or other home and community-based services, waiver program rules, or other ODM rules, a parent of a minor child, a spouse, and other legal representatives are not eligible to bill for Medicaid reimbursable waiver services to an individual for whom they serve as legal representative. So more simply, if a spouse or relative is not eligible to be the direct care worker under this rule, they cannot bill for services. And then the next one, unless otherwise permitted in the waiver program rules, an agency fully or partially owned by an individual's legal representative is not eligible to bill for Medicaid reimbursable waiver services to an individual for whom they serve as legal representative. So I think this goes without saying. So if a spouse or relative is the full or partial owner of an agency, they can also be the direct care worker for an individual under that agency. All right, a direct care worker providing services described in this rule may not verify service provision on behalf of the individual. So this really gets down to verifying service, you know, through a timesheet process like that. If the individual has the capacity to verify service, the individual should verify service. Hopefully that's everyone's best practice now, but if they're able to, they should really be the ones signing off on and verifying any service that's provided to them. If the individual has a guardian or lacks capacity to verify service, then another adult can be identified who is able to verify service. If the person that typically verifies service for that individual is going to be the direct care worker. If no one else is available to verify service, then the spouse or relative with legal representative designation cannot be the direct care worker. So something to explore. Again, this may be a situation where you're talking internally, and feel free to reach out to us if you want to talk about it as well. And then specifically for the participant direction, choices home care attendant service. If the individual is unable to verify service, then an FMS representative will be designated. The FMS designated representative cannot be the direct care worker per G4 of this rule. All right, a few more limitations. A direct care worker may not receive payment from any source for activity other than the direct care for the individual during the time authorized to provide HCBS waiver services. A direct care worker may not provide care to a person other than the authorized individual during Medicaid billed hours. And then again, the rule that I just referenced, participant directed services, if an individual chooses to designate a representative through the FMS, the FMS designated representative may not serve as a direct care worker. Really, the philosophy behind that is it would have been a huge conflict to have a direct care worker, the employee, also acting in a role as their employer. In agency-based settings, that agency is the employer. So that's kind of that thought process behind that. All right, so another limitation is, you know, they're eligible to be the direct care worker. We're now talking about doing our assessment to determine how many hours the individual needs, what we're going to be authorizing that spouse or relative to be doing. So there is a limitation on the number of hours that can be approved. So an individual may receive a maximum of 40 hours per week of paid direct care from their spouse and may not exceed the amount of service the individual is assessed to need. So if the individual only needs 20 hours a week, we'll only authorize 20 hours a week. If they need 40 hours or more, then we can only authorize up to 40 hours. Unless there is an exception to this if more is needed for health and safety reasons. So you'll follow your normal process for determining the number of hours that can be authorized. And then a quick note for participant direction, choices, home care attendant service. You can continue to refer to the choices home care attendant service rule, section B, that also addresses our limitations. And then exceptions to the 40 hours per week can be made due to an emergency that cannot be resolved by allowing another provider to provide the service after the 40th hour. 46 hours is the maximum allowable hours assigned to any one provider. So really think, you know, we can authorize up to the 40 hours if they need 40 or more. And then really kind of authorizing for emergencies is typically, obviously I won't speak for 100% of the cases, but typically it's going to be more acute cases where there's a need that arises really quickly or kind of something that we might anticipate. In order to ensure their health and safety, you know, we need to put in a one-time authorization for additional hours to make sure their needs are being met. So typically it's probably going to be an acute situation. Not saying that it doesn't exist where we would need to authorize something more ongoing, but again, use your internal kind of clinical decision-making here. Reach out to us if you want to talk about any specific situations. So one example that we came up with is the direct care worker's son and durable power of attorney is authorized the 40 hours per week. The spouse needs to attend a medical appointment with the individual to ensure their medical needs are appropriately addressed. Since the individual has forgetfulness, a one-time 3-hour authorization is approved for this. And I made a little mistake there. It should say the son needs to attend a medical appointment with the individual. So apologies there, but they need to go to the appointment. Maybe the individual has forgetfulness. There's kind of a concerning health issue going on, and they really need someone to be able to attend that appointment with them to be able to help that individual follow whatever medical advice is given. Or another example is the individual spouse had a medical concern, is in urgent care. The individual has dementia and can only be left alone for brief periods. Direct care worker, son, and durable power of attorney is authorized an additional 3-hour shift that day to ensure the individual's needs are met until the spouse is home from urgent care. So just a couple examples. Again, you guys are the clinicians. Use your clinical decision-making there. Reach out to us if you have any that you want to talk about. And then Sue, yep, we'll make that update before we send out the final version. Appreciate that. And I guess it's not really a little mistake. That's pretty significant in that scenario, but all right. All right, a decision. So that's basically, here are the qualifications for a spouse. Here are the qualifications for the relatives with legal authority, and kind of here's everything that applies to both, and then just kind of the rest of the rule. So section J, a decision by ODM, ODA, DODD, or their designee related to whether someone qualifies under this rule to serve as a provider or direct care worker for an individual is not subject to notice and appeal rights. So that's included in the rule. And this first is kind of more of an FYI. So there is no appeal process through the Bureau of State Hearings for the outcome of the extraordinary care instrument or the eligibility for a spouse or relative with a legal representative designation to be the direct care worker. It's kind of that philosophy of we're saying no to the worker, we're not saying no to the service. So the service is still absolutely an option. We're just saying no to this specific person being a worker. If a spouse or relative with legal representative designation is not eligible to be the direct care worker per this rule, the PA will review the individual's formal and informal support options to ensure their identified needs are being met. So if we're saying no, we really want to do a thorough review of, okay, these are the needs we identified. Here's how our plan for making sure your needs are being met. When a spouse or relative with legal representative designation is found not eligible to be the direct care worker under this rule, the PA should document the following in the individual's record. The individual was found to not meet extraordinary care. Document the ODM's ECI was completed in the determination, keep the ECI in the individual's file, and easily accessible. The specific reason, we definitely want to be specific in documentation on the reason that they're not eligible, tying it specifically to the rule that the spouse or relative was found not eligible to be the direct care worker. For example, there is another willing and able provider to provide PCS to the individual, and then any kind of details about that. All right. And again, just kind of setting some overall care plan, service plan, and case note expectations. An example of a care plan, there are no willing and available, say it's PCS that we're doing, PCS providers to provide care to Ms. Smith. Goal, the individual's needs will be met, and then intervention, son, Mark, who is also the durable power of attorney, is authorized to provide personal care service to the individual. All requirements in 5164.432 are met. And then if it were a spouse, if the spouse needs to be present, this would be a good place to indicate it. And then really any other information that you think is necessary here as well. And then service plan expectations. This part's important because this is going to be what's shared with the provider. And this is what the provider should be following as far as allowing someone to be the worker. And they should be following your service plan, how you've authorized it. And then so our provider team, when they're doing their structural compliance reviews, will be reviewing that service plan to make sure that they're following that. So this piece is pretty important. Set up your service authorization like you normally would with the units, all that, the fun information, and some additional things to include in the comment section. The direct care worker's name and relationship to the individual, including their legal representative designation, if applicable. And the number of hours they are authorized to provide to the individual. And then really in the comment section, any other information that you think is necessary for the provider to know. And then, Sue, do we have a definition of spouse and definition of authorized rep? Yes, those are included in the rule. I don't have them in the PowerPoint, but they should be in the draft version of that rule, of this rule. And then case note expectations at minimum should include how assessed needs will be met, how health and safety is being ensured when a spouse or relative requests to be the direct care worker and the outcome of that request. And then some things to consider kind of if they're applicable, if the spouse relative is denied being the worker under this rule, specific reasoning as to why. Services are needed from the spouse while a willing and able direct care worker provider is sought. The health and safety needs of the individual may be assured through the spouse serving as a direct care worker, and then the extraordinary care instrument completion and outcome. So just some things to consider as you're doing your case notes. And then I see that I missed a comment a little bit earlier. Just to be clear, a relative that has no legal decision-making authority can provide services per usual. Yes, absolutely. If there's a relative, a friend, whomever they can continue to be the paid caregiver, kind of how you've already been doing it. Great question. All right, so we've addressed most parts of the rule. There's one more piece of the rule I'll address, but before I do that, just wanted to make a couple plugs for some things to also consider. So the big thing is communicating with agency providers and the FMS if it's Choices Home Care Attendant Service. So for agency providers, the PAA will share the service authorization and care plan with the agency provider. And then for participant direction, Choices Home Care Attendant Service, the PA will update the individual service plan, and that service authorization will be shared with PPL through a SAR file each business day. So they'll get your authorization naturally through that process. And it will, have the individual's name, obviously, and then it will have the direct care worker's name as well, which is our authorization for that worker. And then just some things to consider as far as payer source considerations. So as far as kind of us at ODA and the PAA, the spouse and relative with a legal representative designation can only be authorized to be the direct care worker by ODA for the waiver services under C of this rule, which include Choices Home Care Attendant Service, PCS, homemaking, and waiver nursing. So those are really the only services that the PAAs can have the authority to give the authorization for a spouse or a relative with legal decision-making authority to give that authorization. So in these situations, especially with personal care service, just attempt to follow payer source like you normally would. If you're unable to fill those state plan hours, which in this situation, most likely we probably won't be able to, because that would mean we're bringing in kind of another provider. But if we're not able to, really, no matter the reason should be documented and care planned, and then continue with authorizing the waiver service. All right, and so the last piece we want to go over is kind of this transition. So during the PHE, some spouses and legally responsible relatives were authorized to be the direct care worker. So there are definitely a handful of folks that are currently serving in this capacity. So we wanted to give a little bit of guidance here. And in the rule, this was actually recently added. So if you're like, I don't remember this being in the rule, it was recently added to address these. So within 90 days of the effective date of this rule, parents of minor children and spouses of individuals who are authorized to provide paid services will be assessed by care management agencies as appropriate to determine whether they meet the requirements outlined in this rule in order to continue to provide services. So that 90 days is important here. The department wanted to give everyone time to be able to make any transitions and to do these assessments. So that way it wasn't like January 1st, they can or cannot. So there is a 90-day period. So that will be from January 1st to March 31st, the transition period. During the transition period, the PAA must identify which individuals currently have a spouse or legally responsible relative working as the direct care worker for any of those 4 services. And then as soon as you're able to assess each of these individuals and the direct care worker for this rule based on the guidance in this training and ODM's webinars. And then if a spouse or legally responsible relative is not eligible to be the direct care worker per this rule, assist with safely transitioning to another worker provider by that March 31st date. But if a spouse or a legally responsible relative is eligible to be the direct care worker, then you'll just ensure the guidance in this training and ODM's webinars are followed. You know, that your case notes reflect that, service plan reflects that, and care plan reflects that. And then they can continue to be the direct care worker like they have been. Then you'll just want to make sure that each piece of the rule is being followed. And then kind of where needed, update the service plan and send an updated service plan to the provider. And then if you have an individual case, absolutely, again, don't hesitate to reach out to discuss individual cases as needed. All right, and that is the new rule. I believe I got to the questions in the comments. Any additional questions, comments regarding the rule?
Lauren, there was a question. Let's see, you mentioned here that you thought that respite under personal care services was going away from Passport entirely. Is that correct?
That is a great question. We'll look into that and get back to you. Amy, could you add that to the FAQ, please?
Yes, I can.
And thanks for catching that, because I didn't see that one. All right, well then before we wrap up today, and I think we are right on time, any other questions you have for Alicia or myself today regarding all the unwinding stuff? We'll take the silence as a no. Thanks for joining us today. And I hope you have a good rest of your day. Alicia, anything else you wanted to add before we end?
No, thank you everyone for your great questions, and all of this information is a lot. So I appreciate you sitting through it and listening to us talk to you. And we will look forward to getting together, like I said, the FAQs, and it will be along with provider oversight, because some of these questions are actually, they were asked in the provider oversight presentation as well. So definitely we want to make sure. And if any of you have any other questions or concerns that pop up, let us know. Oh, let's see here. Beth just sent something. If another person needs to verify services because the POA is the aid and individual is not competent, how often do they need to sign timesheets? Is end of the week permitted if they live out of town? Lauren, do you want to take that?
Sure. Yeah, I would say it's probably going to depend on the agency and kind of what their best practice is. So I would say the worker and individual just need to work with the agency on that. And then if any issues arise, they can reach out.
Great. So what if HCAS or C? Do you mean the home care attendant or do you mean the Choices home care attendant?
I'm guessing
The choice is home care
That's what I
attendant. Thank you.
figured,
I'm
yeah.
sorry.
No, it's an easy mistake.
You're fine. I'd say my answer is kind of twofold. So with Choices home care attendant service, timesheets are submitted basically twice a month. So the 1st through the 15th is submitted within like 3 days after the 15th. 16th through the end of the month, same thing. So timesheets are submitted on basically a twice a month basis. But it is important who's ever signing off on timesheets is actually able to verify it. So they really shouldn't just be signing off on it if they can't actually verify that what they're signing off on is accurate. So yes, it'll be twice a month, but also another conversation to be had with them is, are you actually able to verify that the information you're signing off on is accurate information? If they can't, that's a whole other situation because they should be able to.
Right.
Thank
And
you. I
just to
anticipate that. I'm sorry, Alicia. I just said I anticipate that question coming, so I appreciate having a conversation on the front end about it. I'm sorry, I didn't mean to interrupt you, Alicia.
No. I was
Yeah.
just going to add. So, I mean, and definitely, I mean, over the years and with experiences, I mean, it seems like if there is a person who wants self-direction and they are in any way appropriate and it's going to meet their needs, it seems like, at least from my experience, that we were always able to work something out with most families. There was always somebody, it appeared, that could fill one of these roles, so to speak, because you have a lot of triads. You have a lot of individual worker and then an authorized representative. So, keep that in mind. And like Lauren said, if you have questions about anything in particular, the other thing again to remember is our technology now allows us to see a lot more than what used to be done by someone that maybe, like I said, if they live on the other side of town and they don't see you that frequently. Health and safety is our biggest concern. So, we want to make sure that these folks are seeing what's being done and that the person's receiving their services. And obviously, if they're being paid to keep up housework and the case manager shows up and, it's just like a mess, it's like, okay, somebody's not doing something here, and the person doing the oversight really needs to make sure it's being done. So, again, use your clinical judgment. And if any of these can work out, we want to meet everybody's person-centered goals and that sort of thing. So, with all of our services, same deal. If you have any questions or concerns, let us know. We'll put out the FAQ within a couple days. And like Lauren said, we will send out this recording and then we will send out the PowerPoint. So I know there was one area she was going to change. And then, so we'll send that out. So you all have that information as well. And that way, if people weren't allowed or weren't available to see today or we're out on vacation or whatever, that you can have all these links to all of our different programs. I know Meredith did an assisted living one yesterday. So in any event, if you don't have anything and you need it, let us know and we will make sure that we can get the trainings to you and your staff so that they can look at it themselves if they want. And everybody learns information at a different point. So, or at a different method or way. So we just want to accommodate that. So thank you all for sitting through this and listening to us. And we appreciate your participation and questions. So everyone have a great holiday if we don't see you or talk to you before. So
Thanks, everyone.
thanks, everyone. Okay, bye-bye.
Bye.